diagnostic approach to grown-up congenital heart disease. I think this is a very timely issue, and we like to hear from Dr. Debika Chatterjee, madam, and she has come from Kolkata to Bangladesh to enlighten us. Welcome, madam.
Thank you, chairpersons, and good morning, everybody. I'm so happy to be in Dhaka once again because I feel very happy to be with you, to be in Dhaka because we speak the same language, moner mil, bhashar mil. So thank you very much for inviting me. And I'm going to speak on diagnostic approach to the grown-up congenital heart disease. Grown-up congenital heart disease, or nowadays we call it adult congenital heart disease, is a growing problem. When these patients come to the adult cardiologist, general cardiologist, either this disease is incidentally detected or these patients come for long-term follow-up with known congenital heart disease from their childhood. Because of the good pediatric care, good surgical care, the patients are living for long, till the age of 50, 60. And some patients come for post-operative follow-up of palliative or corrective procedures for congenital heart disease which were done in their childhood. Whichever is the way of presentation, it's always a great diagnostic challenge for adult cardiologists, because the major focus of adult cardiologists is directed towards the acquired heart disease, ischemic heart disease, rheumatic heart disease. And many of the adult cardiologists are unfamiliar with the anatomical and functional complexities of cardiac malformations associated with congenital heart disease. And there is no specific training for congenital heart disease. A large gap exists between the pediatric cardiology and the adult cardiology, and which is very difficult to bridge this gap. Moreover, on top of this, the literature is very sparse. The case reports are mainly on the unusual lesions rather than the common problems of the congenital heart disease. Echo imaging in adult is not favorable, not as favorable as children, because we use a low frequency probe where we compromise with the resolution of the image. And sometimes the adult cardiologists come across with the patients who have sudden deterioration in the clinical status in this group of patients, as happens during pregnancy. Also, the post-operative follow-up is a problem. There is a suboptimal echo view because of the scars. Often there is unavailability of the previous documents, surgical notes. So it's a problem in determining the basic diagnosis. And also, some of the adult cardiologists have lack of knowledge of the residua, which is quite normal, and sequelae of operations like residual shunt, pulmonary vascular disease, ventricular dysfunction, infective endocarditis, blah, blah, blah. So, life is full of challenges. Never mind, we always take the challenges, and echo in adult congenital heart disease can be as accurate as in children, provided we perform and interpret the echo in adult congenital heart disease following a systemic approach. We start from the clinical examination, listen to the heart sound clearly, murmurs, we look at the oxygen saturation, look for the previous documents, surgical notes. If they are not available, at least look for the scars in the body. Often patients cannot say whether he or she had the surgery in their childhood. And then after that, we will systematically assess the cardiac anatomy, morphology, function, hemodynamics using a sequential segmental analysis. Now, what is that? What is that sequential segmental analysis? Well, by that, we mean that we follow the blood flow into the heart, following the systemic and pulmonary venous drainage into the heart. Then we follow the blood flow inside the heart through the atria, atrioventricular valves, ventricles, and then at last we follow the blood as it goes out of the heart. That is through the semilunar valves and great arteries. So, to take that segmental approach, we start from the determination of position of the heart. You see, position, yeah. What do we mean by that? We mean by that the orientation of the heart from base to apex. If the apex is directed towards the left side of the patient, we say levocardia. If it is directed towards the right side of the patient, we say dextrocardia. By keeping the probe in the subcostal window with the index mark at 3 o'clock position, we tilt the probe anteriorly. So after looking into this, next is determination of the situs. What do you mean by that? See, again we do it from the subcostal view, keeping the probe in the subcostal. We keep the index marker at 3 o'clock and tilt the probe posteriorly. As we do so, we can see the vertebra. This is the spine of the vertebra. On one side of the vertebra is one great vessel, and on the left side is another great vessel. As I put the color flow, I can see the pulsatile aorta on the left and IVC on the right. To confirm that this is aorta and that is IVC, we put the sample volume in the aorta and get the pulse wave Doppler. Aortic flow is pulsatile. On the other hand, IVC flow is a continuous flow. So this is situs solitus. IVC on the right, aorta on the left of the spine. On the other hand, look at the situs inversus. This is the spine of the patient, spine of the vertebra. Aorta on the right, IVC on the left. So that is, situs is done. Next, we follow the IVC into the atria. IVC keeping again in the at 12 o'clock position in the subcostal view. We follow the IVC draining into the right atrium. And it is joined by the hepatic vein. And next, we see the pulmonary veins. See, it is difficult in adult to visualize the pulmonary veins, but nowadays with the good quality machines, it is possible. This is an adult patient. Look, I can see 1, 2, 3 pulmonary veins at least. So they are draining, and we do the pulse wave to see the flow pattern, systolic, diastolic, and atrial flow reversal. Following this, a very important step is to identify the ventricle. Which side is LV and which side is the RV. For that, we go to the apical four-chamber view. We look at the atrioventricular valves. Now, look, this valve is a bit up than this valve. This particular valve is apically placed, more towards the LV apex. So we say this is tricuspid. And the ventricle, which follows the tricuspid valve, is the right ventricle, which is having multiple trabeculations and a moderator band, a thick, bright band at the apex of the RV. On the other hand, look at the LV. It is very clean, free of trabeculations. It's clean shaped, whereas the RV is highly trabeculated. So after identification of the ventricle, we go to see the relation of the great arteries, which artery is arising from which chamber, and then we look. Here you see, this is RA, RV, and it's giving origin to the great artery, which is bifurcating. So this has to be pulmonary artery. The pulmonary artery bifurcates, aorta doesn't. On the other hand, in the apical fourth chamber, aorta is arising from the LV. So this is done. Now we go to the parasternal short axis view to see the relation of the great arteries. Well, in normal relation, we get a sausage and circle appearance. What do you mean by that? Aorta is posterior, pulmonary artery is anterior, and it looks like a sausage. And aorta looks like a circle. So circle, sausage appearance. That is the normal appearance. The pulmonary artery wraps around the aorta. On the other hand, if there is discordance of ventricular arterial connection, where RV gives origin to the aorta and LV gives origin, RV gives origin to the aorta and LV gives origin to the pulmonary artery, you see it looks like this. From the apical fourth chamber, I tilt the probe anteriorly and the great artery which opens from the LV is bifurcating. So that is pulmonary artery. Whereas the great artery which is arising from the RV is not bifurcating. So that is aorta. And how is the orientation in the short axis in this TGA patient? This is called transposition of great artery. Aorta arising from the RV, pulmonary artery arising from LV. So in the parasternal short axis, the appearance is, you see, double circle we see. Aorta is anterior and to the right, and pulmonary artery is posterior, because this is bifurcating. From the aorta, coronary artery arise. This is for transposition of great arteries. And there is another condition called congenitally corrected transposition of the great artery, where RA is connected to LV and LV is connected to pulmonary artery. On the other hand, LA is connected to RV through tricuspid valve and RV is connected to aorta through aortic valve. So how does that look like? Look at this patient. As I said, the tricuspid valve is apically placed. Here it is apically placed. And the ventricle, which follows the tricuspid valve, is RV. Now I try to open the great arteries. The first great artery, which is arising from right-sided left ventricle, is the pulmonary artery, which was bifurcating. And this is the, look here, follow it. This is bifurcating. But the great artery, which is arising from the RV, is the aorta. And in congenitally corrected transposition, aorta looks anterior and to the left, and pulmonary artery posterior. Next, to end the segmental approach, we do the suprasternal view. We look at the flow pattern, whether they are laminar or turbulent. After this, we go to rule out any shunt at any level, interatrial septum, interventricular septum. We look at the valves, and then we look at the LV function. These, if we follow this segmental approach, we are not going to miss any diagnosis. But if one step is missed, we may miss some case. Look at this patient. 36 years female, came to us with outside diagnosis of dilated cardiomyopathy, and this female was running from here to there with this diagnosis of DCM. Then at last, she reached our hospital. Now, as I did the parasternal long axis, yes, I could see dilated LV with generalized wall hypokinesia. LA was enlarged. Even in the apical fourth chamber view, I could see that LV is dilated. You see, it looks like dilated cardiomyopathy with generalized wall hypokinesia. Valves were more normal morphologically, though there was functional MR mild to moderate, but otherwise the valves were normal. There was no intracardiac shunt. So what should be my diagnosis? Should I report it as dilated cardiomyopathy? Of course not, because I haven't seen the subcostal view. Look at the subcostal view. I look at the aortic flow. It's looking like, continuous and a very low velocity flow. Absence of pulsatile flow in the abdominal aorta. And then look at the suprasternal view. The suprasternal view shows the arch is okay. Initial part of the descending thoracic aorta is okay, but the distal part of the thoracic aorta was absolutely narrow. And as I put the color flow, I could see the turbulent flow. You see, turbulent flow is going through the lowermost part of the descending thoracic aorta, which could be seen in the suprasternal view. And as I did the CW Doppler, I could see a high velocity flow in the systole with diastolic runoff. So this is a typical flow pattern of coarctation of aorta, which was missed. And often the diagnosis is delayed in this type of patients. Once they develop the heart failure, they come and you find out that there is coarctation, which might be discrete or a long segment. It may be high or it may be low. So your index of suspicion should be very high for coarctation of aorta if you get a patient of dilated LV, LVH, LV systolic dysfunction. So always look at the subcostal view for absence of pulsatile flow in the abdominal aorta, and in the suprasternal view to never forget to look at the high velocity turbulent flow. So this is the importance of utilization of all views in diagnosing congenital heart disease. But mostly in the, cardiologists, general cardiologists come across with the patients of ASD. Around 1/3 of the adult congenital heart disease are patients of ASD, which may remain undiagnosed in the childhood. They come at adulthood, and ASD never cause any symptom. And in the parasternal long axis, you get the dilated RV, so also in the apical fourth chamber. As soon as you get the RV volume overload, always suspect ASD unless proven otherwise. So you go to the fourth chamber with color flow, and that confirms the left to right flow in the ASD. Now in the fourth chamber, in the adult patient, we try to go towards the sternum. That gives a better angle to view the IAS. And also never forget to do the subcostal view, because this is the optimal image for ASD, as IAS is better seen and it's perpendicular to the ultrasound beam. And when these patients come after a surgical closure or device closure, this looks like this. You can see the patch. We see whether there is any residual left to right flow. And also we look at how is the RV-LV doing, and whether there is any remaining pulmonary hypertension. Now, the ASDs may be sinus venosus, where in the fourth chamber and the subcostal we may not be able to see. But these patients would come with pulmonary hypertension. From the TR you can see. And here, these are the patients where we need to do transesophageal echo. And as we do, and as we go to the bicaval view, we see there is a dropout and left to right flow at the junction of the SVC to the RA. So these are the ASDs, sinus venosus ASD. The 15% of the ASDs are sinus venosus, and they...
Madam, time is up.
Time is up. So will you allow me to or what? Tell me. There are few cases.
Okay, madam, one more minute.
Achha, okay. So there is another type of ASD called ostium primum, so where we get to see no tissue near the tricuspid and mitral valve. And look at these ASD. These are the patients which come in adulthood. Though it is an ostium secundum ASD, the patient is having only a intolerance, but we see the oxygen saturation is 90%. And I see the left to right flow, but then why the oxygen saturation is 88%, 90%? pH is very high, its TR gradient is 77. So I do bubble contrast study. See, as I do it, look, the bubbles, agitated saline, is going from RA to RV, also to LA at the same time. So this confirms that the patient is having ASD with bidirectional flow. Should I stop?
Probably, yes, madam.
Okay, fine. There were some cases, it's all right. For time's sake, I think I could explain you how systematically you should approach the VSDs and everything. You know, see, you will never miss the diagnosis, the importance of going to the patient with the echo in a segmental, systematic way is that you are not going to miss a single diagnosis of adult congenital heart disease. Thank you.
Thank you, madam.